Welcome back. This is Ian Bodford.
And Liang Liu.
And this is the Clinical Correlation. Today's case is...
This is a 36-year-old female with no significant past medical history who presents with lower abdominal pain. The pain began suddenly this morning and is described as an uncomfortable sensation in her abdomen. It is associated with some nausea but no vomiting.
She reports a positive pregnancy test at home last week, but has been having metrorrhagia for the past year, so she is unsure of the timing of her last menstrual period. Further history reveals that she has had 2 miscarriages in the past with 1 healthy child at home.
The patient is taken to a critical care room because her vitals are significant for hypotension and bradycardia.
On exam, you confirm the bradycardia. She is alert and oriented and mentating normally. Her belly exam shows signs of peritonitis.
The point-of-care urine pregnancy test is positive. Bedside ultrasound shows free fluid in the pouch of Douglas and no intrauterine pregnancy.
Something wasn't right here.
You place a phone call to the OB-GYN docs.
Likely this patient is suffering from a ruptured ectopic pregnancy. While our patient came in with a positive pregnancy test at home, it is not uncommon for this to happen.
It should be on the differential in any female patient of reproductive age because it is the leading cause of maternal death in the first trimester. It occurs in up to 2% of all pregnancies and in even higher percentages of those pregnancies that present to the ED.
If a patient has had a prior tubal ligation or IUD and a positive pregnancy test, it is an ectopic pregnancy until proven otherwise. Up to 50% of these pregnancies are ectopic.
Even if an intrauterine pregnancy is visualized, 1 in 4,000 of the general population and 1 in 100 of in vitro fertilization patients could potentially have a heterotopic pregnancy.
The odds ratio is calculated by dividing the risk of having the disease in those that are exposed to the risk factor by the risk of having the disease in the non-exposed population.
Here, the odds ratio for several risk factors in ectopic pregnancy are shown, but keep in mind that in over half of all cases, no risk factors are present.
Ectopic pregnancy is a diagnosis that must be considered in all female patients of reproductive age who present with abdominal pain. If the ectopic is ruptured, patients could potentially present in shock and have rebound tenderness on examination of their abdomen.
Early non-ruptured ectopics might only have abdominal or pelvic pain and perhaps some vaginal bleeding. Workup of these patients should include a CBC, quantitative beta-HCG, type and screen with RH factor, and a bedside FAST or pelvic ultrasound if available.
So you have a patient who presents with abdominal pain and a positive pregnancy test. How would you manage the patient if ectopic pregnancy is suspected? WikiEM has a 4-step algorithm that is fairly concise.
Step 1 includes assessing the patient for shock. Keep a close eye on their vitals, but be aware of the paradoxical bradycardia that occurs in the setting of significant hemoperitoneum, as in our patient. Bedside FAST can be useful to look for free fluid in the abdomen. A positive pregnancy test, hypotension, and free fluid in the abdomen requires an immediate consult to OB-GYN for definitive surgical management.
Patients in shock could potentially not be perfusing their kidneys or producing urine. Therefore, a urine pregnancy test may not be obtainable. Serum HCGs take a while to come back. Is there any other way to detect pregnancy at the bedside?
Most commercial pregnancy tests are approved for use with urine and serum, but not whole blood. In 2012, Fromm et al. Performed a study showing that whole blood also performed well on urine pregnancy tests. The sensitivity was 95.8% versus 95.3% with urine. The specificity was 100%. Believe a positive result, but confirm with other means as soon as possible. Keep in mind that this practice may not be acceptable at your hospital, so know your individual institution's policies.
If shock is not present, step 2 is to perform a pelvic ultrasound. Transabdominal ultrasounds can be used if the beta-HCG is over 6,000, but if no IUP is seen or is indeterminate, a pelvic sono will need to be performed anyways.
If an IUP is seen and the pregnancy was not a product of in vitro fertilization, then ectopic and heterotopic pregnancies are essentially ruled out.
Step 3 is to consult OB-GYN if the HCG is above the discriminatory zone of 1,500 to 3,000 milli-international units per milliliter, and no IUP is seen on pelvic sono, as this is an ectopic pregnancy until proven otherwise.
If the patient has a beta-HCG below the discriminatory zone, with no intrauterine pregnancy seen on sono, and minimal to no abdominal pain with stable hemodynamics, they should have a repeat HCG drawn in 48 hours. In normal pregnancies, the HCG should increase by at least 50% in 48 hours. With ectopics, HCG will increase slowly or decrease.
Rogam should be given to all Rh-negative women with a confirmed ectopic pregnancy.
Methotrexate can be used to medically manage ectopic pregnancies in many cases. However, there are a fair number of contraindications, so consultations with OB-GYN should occur prior to administration.
Emergent laparotomy is indicated if the patient is unstable, and a laparoscopic procedure can be done if there are contraindications to methotrexate.
To summarize, any female patient of reproductive age who presents with abdominal pain needs a pregnancy test.
In patients with abdominal pain and unstable vital signs, look for free fluid with your ultrasound.
Whole blood can be used with urine pregnancy tests. Just know your hospital's policy on doing this.
Any Rh-negative mother with a proven ectopic needs Rogam. Consult OB-GYN for definitive management.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLLou.
Thanks for listening.